Good morning and welcome to SSMC Answers. My name is Matt Getman, Chief Medical Officer here at SSMC, and I'm so happy that you've joined the program. As you may know, SSMC is a very large hospital in the UAE that's dedicated to the treatment of serious and complex medical matters. We have a great team that are here to help patients from a holistic standpoint, thinking about the impact that disease has on the mind, the body, and the spirit. We believe in the power of care, trying to individualize treatments to each patient's needs. We also want to focus on prevention and education so that we can teach our patients and family members alike exactly what's going on with their specific medical concerns. As part of SSMC Answers, each month we ask a member of our staff to talk with us about common medical issues. Today's topic is ovarian cancer. The reason why we've selected ovarian cancer today is because it's actually World Ovarian Cancer Awareness Day, so very fitting that we would be having this conversation. I'm also absolutely thrilled to welcome back to the program Dr. Muhyiddin Saud, who is our Chair of Obstetrics and Gynecology and an international authority on ovarian cancer. He'll be giving us some tips and some awareness points about this disease and the impact that it has on women across the world. Welcome, Muhyiddin, and thank you so much. Maybe you could start by talking a little bit about how common is ovarian cancer in the region and across the world.
Thank you, Matt. And again, it's a pleasure to be here and to answer some of the questions that our audience might have. But ovarian cancer is not the most common gynecological cancer, certainly. Worldwide, we see around maybe 250,000 women with ovarian cancer. The problem with these cancers is that most of them present late. So the mortality from the ovarian cancer is very high. It's like 140,000 women who die from this. Again, because many of these cancers do not present with early symptoms. They are discovered quite late. So worldwide, it's about maybe the 8th most common female cancer. Breast cancer is the most common across the world. In the GCC area, it's like the 11th. Okay. But remember, in our Emirates, the majority of the population are expat and not local. So the statistics may differ between different populations depending on their background. But again, the salient feature of most ovarian cancer is late presentation, late discovery, late stage at discovery, and hence the survival is not that good. That's why we really want to make it like an awareness month on how to be aware of the symptoms and signs of ovarian cancer.
Well, appreciate those introductory comments. So, what I'm hearing is it's really important to detect it as early as possible. So what are some of those warning signs or symptoms that women need to be thinking about?
Okay. So most of these ovarian cancer, about 75% are discovered late because the symptoms that they give are so non-specific that many women will just disregard them coming from other areas like the GI, the gastrointestinal tract. So the symptoms are non-specific. However, studies have shown truly that only 11% of what looks like an early ovarian cancer are truly without symptoms. The symptoms are vague, like bloating, like vague abdominal pain or pelvic pressure or pelvic pains, some distension, that many women will say this is from the gastrointestinal tract. This is like, just bloating from gas, for example. Very rarely do they have very specific symptoms like pain, for example. And again, many women will not attribute this pain to ovarian cancer, but for example, to ovulation, to their menstrual cycle. So the symptoms are non-specific. That's why we want women to be aware that certain signs may be more serious, and the importance of regular checkup with their physician, which many of our women here may not do, may not feel the importance of doing.
So are there a lot of changes that happen with menstruation for women that have ovarian cancer?
Normally, no.
Okay.
Ovarian cancer does not, like other cancer, for example, endometrial cancer that shows some abnormal bleeding, or cervical cancer, some bleeding after having sexual relation, for example, or vaginal discharge. Ovarian cancer does not really present with a lot of abnormalities in the menstrual cycle, except a very rare group of these ovarian cancer, which we call the stromal tumors, which may be associated with hormonal secretion that will affect the menstrual cycle. Otherwise, the majority of the ovarian cancer, which we call the epithelial ovarian cancer, do not have associated menstrual irregularity that women can detect.
So the ovaries, of course, are reproductive organs, and each woman has 2 ovaries, and they're small. So with those being very small organs, how can they cause all of these GI symptoms that you mentioned, the bloating and those sorts of things?
Okay, so for the majority of ovarian cancer, which we call the epithelial, because the abdomen and pelvis are hollow organ, these tumors can grow to big sizes, and the woman will not feel a lot of pain. I mean, we've seen them grow to 30, 40, 50 centimeter and really growing, but yet the woman will not feel except some distension and fullness. So they are not aware of them until the tumor spreads into the abdomen. So it involves the small bowel, the large bowel, or is filled with fluid in her abdomen. Then she starts having these bad symptoms. Otherwise, the early cancer, even when they grow, because the abdomen and the pelvis are connected and they are hollow organ, it can grow big without any symptoms. And remember, a woman who is pregnant with twins, with triplet, with quadruplet, has a huge abdomen, and the abdomen distends. And if it does very slowly, it causes no symptoms.
Now, are there screening tests that are recommended then for ovarian cancer?
I think we have to separate those people who are at very high risk of developing ovarian cancer from those who are at low risk, like everybody in the society, who are at low risk of ovarian cancer. Now, unlike breast cancer, cervical cancer, colon cancer, where we do have very effective screening program for them, like doing mammogram for breast, doing colonoscopy and blood test for the colon cancer, and doing the regular pap smear and the HPV test for cervical cancer. Unfortunately, screening for ovarian cancer has not been really very fruitful, and there is a very large study that comes from the UK. It's called the UK CTOC, that took 30 years to finish, and showed that screening for ovarian cancer in low-risk women is not really cost-effective. So, except for warning women about certain signs, and the woman coming on a yearly checkup to do her checkup with her gynecologist, we really don't have very good screening program for the regular low-risk woman. Now, having said this, women who are at high risk, and we can talk who are women at high risk, have a different program for screening, definitely.
Yeah, sounds like a very important point. Who are those women that are at higher risk?
Okay, so women who are at risk are women, for example, at a certain age. Let's say in the peri and postmenopausal women. Women who have not had children, for example. Women, for example, who have not breastfed are a slightly high risk. It doesn't mean that they are higher risk. But those who are really at a very high risk are those who have a family history of ovarian or breast cancer, especially those that have been tested and have a genetic mutation that puts them at a risk. And I always like to remember women about the story of Angelina Jolie. I mean, before we were talking about genetic analysis and testing, when we used to talk to women, they used to say, what are we talking about? Once Angelina Jolie, which is a famous actor, whose mother had breast cancer, the mother was tested. She had one of these genes, the BRCA1 or BRCA2 genes. And then Angelina tested herself, and she had the same gene. She went ahead and did bilateral mastectomy and then removed her ovary. So this is very important. When we have a woman in the family, even a single woman, who have either ovarian cancer or who have lots of other women who have breast or ovarian cancer, then these patients have to go to a geneticist, a cancer geneticist, to really have the family tree, then see if they are eligible to be tested for these genes, and if they are tested, then the patient herself can be tested for that gene mutation, and if she carries it, then she has to be referred for a genetic counseling and then possible risk-reducing intervention. It does not have to be surgery, but there are certain risk intervention that we can do to help these women decrease their risk of getting ovarian cancer.
Okay. So there's a lot of if you are predisposed with the family, that's a really important point. You need to be checked, especially if you have that history of breast cancer, ovarian cancer. Now, there's another disease entity called Lynch syndrome, which also can be associated with colorectal cancer. I understand that's
Yes.
also associated with this
Exactly.
group.
So when we take a history of cancer, among the history that we get is a history of colon cancer in the family, because certainly that will increase the risk for certain breast, ovarian cancer, and other cancer. If they test positive for that particular mutation, and there are many mutations in the Lynch syndrome that we look for, if they are positive, then the patient is tested, and if she carries it, then she has to be put in a program of screening, not only for her colon, but for her ovary and other cancers as well. So certainly, that's why you need a specialist to do this.
Well, and it
screening.
sounds like that's exactly the model of care that we have here at SSMC, where we're thinking about one patient, but in many different modalities of care.
Exactly. So it's a holistic approach. I mean, we don't take the history of a single cancer and go for it, but it's a holistic approach looking at what genes she has, and even if she doesn't carry a genes, she might be at a higher risk. So their follow-up and their screening and their modality of intervention, which may be medical, it may be an intensive screening program, or it may be a risk-reducing surgery that we can offer. There are so many things that we can do, and depending on the pedigree of the family, depending whether she carries a genes or not, we put a program for them. It's not a one for all. It's really something that we individualize, and it's a multidisciplinary care that involves a lot of people in the program, a lot of physicians, a lot of care.
So individualized care really is
Yes.
the key to this disease, like we've seen with so many other entities. Do you have
You know,
thoughts?
I'm sorry, but that's important because it's not only important to have that history, but it's the pedigree, because the age of the patients who had the cancer makes a big difference at what age we start our surveillance, our intervention. So that's very important, as you said, to individualize to the genes, to the patient, to the family history, to the ages, etc.
Well, and once you know that let's say the mother had the diagnosis, now for the children, for the daughter, now you would start that screening earlier, I would guess.
Yes, I think this is very important because they come to us and say, I have a 9-year-old, I want to test. And the answer is no.
Yeah.
Definitely no.
Right.
We really don't, we look at the history and the ages of the next of kin, the earliest. Normally these cancer, if they usually attack at an earlier and earlier age. Usually we start the intervention and the testing 10 years earlier than the next of kin which has the earliest cancer, but never really at a very early age. Usually not before the age of 25, because we're going to put a lot of anxiety on these young women or children that we should not do. Okay, and the testing and the screening differs with what age group. Certainly we don't screen at the age of 25 the same thing that we screen at the age of 45 or 60. That has to be really individualized to the family and to the age of that particular person.
Okay, I appreciate that discussion. So if you have a patient where you're suspecting that they might have ovarian cancer, they're coming in with these symptoms, then what are those steps that are taken to, be absolutely certain that's what they have before they think about treatment?
Exactly. So when we have a patient who has symptoms that looks like they may have ovarian cancer, they don't have to be. But the first thing is a good history. I mean, a family history and a personal history on them. The second thing, a very targeted exam, looking at possibility of where the cancer can be. And it doesn't have to be only in the abdomen and the pelvis. Actually, it's a holistic exam for the whole patients. And then after that, we usually image. And normally we do the imaging in the clinic. A lot of us have ultrasound in the clinic, either an abdominal ultrasound or a vaginal ultrasound if the patient is suitable for that test. If we diagnose or we suspect on our imaging in the exam, by exam and by the ultrasound, the next step is a better imaging to see better what we are looking at, because many a time we see a structure on ultrasound we're not sure of, it doesn't have to be cancer. So we ask for a better imaging, which is usually an MRI or a CT scan. An MRI is probably better, as well as depending on the age of the patient and what kind of imaging we have by ultrasound, some tumor markers. So these are the very early steps, the exam, the imaging, and the more advanced imaging. Once we have this and we put the patient as a very suspicious for ovarian cancer, then we have to decide how to manage them.
Okay, so now the tumor marker would be the CA125. Is that the most common used?
Well, again, it depends on the age of the patient and what we are suspecting. If we are suspecting the most common type of ovarian cancer, which usually occur after the age of 40, 45, 50, and after menopause, we do get the CA125. This is the most common marker. And for the epithelial ovarian tumor, we like to also get the other marker, which are CA19-9 and CEA, which may point us either to a different types of epithelial ovarian tumor, or possibility that this ovarian tumor actually is coming from somewhere else. It's metastatic from the gastrointestinal tract or from the breast for that matter. Because sometimes ovarian cancer may not be starting from the ovary, but actually coming from other part of the body, basically the breast or the GI. So we do these tests. Now, if the patient is young, then we have different set of tumor marker, because this is a different type of ovarian tumor that develop, you know, just after puberty or in the reproductive age group, which are called the germ cell tumor or sometimes the stromal tumor. So we target the tumor marker depending on our suspicion of which type of ovarian cancer it is.
Once you've made the diagnosis, now what happens from a standpoint of treatment?
Okay. Now, once we are very highly suspicious that this is definitely cancer, we divide the patient into different groups. First, by age, because certainly the treatment of certain germ cell tumor and stromal tumor which occur in the younger population, in which most of the time it's a very early stage. It has not metastasized. Sometimes it does, but most of the time it's not. And we are interested in preserving their fertility, in keeping the ovary, in keeping at least one ovary, or in keeping the uterus for their fertility. And those patients who are older, usually peri and postmenopausal, and we are suspicious that it's an epithelial ovarian tumor. Okay, this is one. The other thing is that when we diagnose them, what do we think the stage is by our clinical assessment, i.e. by exam, by imaging, and by tumor marker? Is this an early cancer that's limited to the ovary, or it's really advanced? We see that by imaging, she had tumor in the abdomen, in the, you know, the fat pad around the colon, in the lymph nodes, or she has some fluid in the abdomen, she has fluid in the lungs. So depending if we think it's an advanced stage or it's an early stage. Now, for the majority of the tumor, these are epithelial, peri and postmenopausal, and advanced. Here we have two things to decide. With our evaluation, does it look like it's really very advanced and we cannot operate? For example, she has a lot of fluid in her lungs. She has tumor in her liver, okay? This is very advanced. That surgery a priori is not really indicated. So what we do, we get a biopsy, we aspirate the fluid from the lung, from the abdomen, we take a biopsy from the omentum, or we do a laparoscopy. We look inside with a keyhole suture to see really it is advanced. Then we give them drugs by IV, by their veins, 2 or 3 cycles of chemotherapy, shrink the tumor, make the patient better suited for surgery, because some of them are so sick they really cannot tolerate surgery. And after that, if they respond well, go for the surgery.
Makes sense. I understand. Now,
or no, even if they are advanced, we can go ahead and do the surgery, which is better. It's always better if we can do surgery first, even if they are advanced, and then follow by chemotherapy. Now, for those patients who it looks like it's early, or our imaging there is only in the ovary, or she is really young and we want to try to preserve it, sometimes we start with a laparoscope, you know, with a keyhole imaging where we look inside. It is limited. We remove the ovary, and it's very important, and we warn our patient, these have to be taken intact. We should not put a needle to biopsy it to see if it is cancer or not. This is a no-no. And even if we remove it with the laparoscope, it's very important to remove it intact. We put it in a bag. We take the bag out from the keyhole, and then we depress the cyst and take it out intact. It should not spread, because we see a lot of patients coming with us with surgeon trying to remove them with the scope, rupturing them, because now their stage is higher. We may not need chemo, but if they rupture them, they haven't been staged properly and they need chemotherapy. So it's very important this to be done only by really people who know how to do this. Frequently, we have to send for frozen section during our surgery. We take it out, we send it for our pathologist. We tell them, please tell us, is it malignant, is it cancer, or is it benign, and what type of cancer? And depending on what we get, in the same surgery, we continue the staging. What we see coming referred by our colleague is that they remove it and they close, and then they get surprised that the pathology comes at cancer, and now what we do? We really haven't done our patient a favor. That's why it has to be studied well before.
I can see the importance of the multimodality team, the importance of having the pathologist right here like we do, so that as tissue samples are removed, they can be reviewed
Immediately.
And making certain that biopsy is not done unnecessarily, which can result in spillage of tumor, which makes this a much more difficult problem to treat.
Exactly. When they look like they are only limited to the ovary. Of course, when they are metastatic, it's already spread. We really don't matter. And what we do with these, Matt, we usually present these cases before we do our treatment to our multidisciplinary team. Every Tuesday at noon, we have a tumor board where we have oncologist, our chemotherapy oncologist, our pathologist, our radiotherapist. They are all in the same room, and us, and we usually present these cases ahead of time, and they say, this is our plan for treatment, and we get a consensus on the treatment. No, go for surgery before. No, let's go for chemotherapy before. You know, we're not sure about this. Let's do a laparoscopy, for example. So this is the MDT, the multidisciplinary team, that is really very important, and is not unique for SSMC, but certainly is done for every patient.
SSMC has something called HIPEC.
Yes.
Tell me what HIPEC is.
Okay, so in some situation where we think, especially for this epithelial ovarian tumor, where the patient comes in with very advanced stage, and we don't operate a priori, you know, we do the chemotherapy. In these patients, if we go in and remove all the tumors, and this is what we call no residual disease, and it's very important to say, you really have to have people who are specialists in this type of surgery, because they are tedious surgery, where we go after removing every single small piece of tumor, even if it's a millimeter. We spend hours in the abdomen trying to remove everything, because studies have shown that one of the most important prognosis, things that will tell us how long the patient will survive, that when you finish your surgery, you leave nothing inside. No matter how long the surgery, as long as it is safe for the patient. Of course, some patients, you know, may be too sick to undergo this surgery. Now, when we finish this surgery and we have nothing inside, some studies have shown that if we bathe the abdomen with chemotherapy heated at a temperature of 42 degrees, normally it's called cisplatinum, for about 1.5 hours. And if we bathe it, okay, these patients do better than if we give them just chemotherapy after the treatment. And this is called hyperthermic intraperitoneal chemotherapy. But it's not for everybody. It's not for all cancer. And it's only specific to certain, there are only few centers in the Emirates that do this. And SSMC is unique for this.
Well, again, catering that treatment, which is so important. There's been a lot of questions that have been coming in. I'm going to go to a few of those. One of the first questions that's coming in is, are patients with polycystic ovarian predisposed to ovarian cancer?
Okay, no. Actually, patients with polycystic ovarian syndrome have irregular menstrual cycle. And this sometimes can be associated with a slightly higher risk of endometrial hyperplasia and cancer, the well-differentiated type. So they really are not a higher risk for ovarian cancer, but they may be at a higher risk for endometrial hyperplasia or cancer. But again, if they are monitored well, they are treated well, that cancer risk is very, very small.
And do ovarian cancers always originate from cysts? This is another question that's coming in.
I think this is a very frequent question, and that's a very good question. Women develop cysts all the time. Every month the women develop a cyst that goes to about 3-4 centimeters and usually goes away. And most ovarian cysts that we see are actually not cancer, are tumor. So most ovarian tumors do not develop from the benign cyst, okay? Usually they develop as cancer from the beginning, okay? So no, a lot of the cysts that we see are not cancer. That's why when a woman has a cyst, there are certain criteria for these cysts to be really highly suspicious for cancer. And there are very good ultrasound criteria and MRI criteria that will help us differentiate a benign cyst from a malignant cyst, for example.
Another question coming in is about endometriosis and the risk that endometriosis might have on developing ovarian cancer.
I think that's also a very good question, because we have an increasing incidence of endometriosis in our population. And many a time this increased incidence comes from delaying their fertility to an advanced age. So endometriosis is very common. Now, endometrioid ovarian cancer and clear cell carcinoma are very rare. However, there is now data to support that some women with endometriosis are at a slightly, and I say slightly, higher risk on the long run of developing something called endometrioid ovarian cancer or clear cell carcinoma of the ovary. Studies have shown that these might have these cellular changes that are common to both, and these are at the molecular level, at the cellular level, where they might have. The majority of endometriosis patients will not have endometrial cancer, but we have to survey them.
What healthy habits can women take to decrease their chance for ovarian cancer?
Okay. One thing that can decrease patients who are at a higher risk for ovarian cancer, okay? We've known that women who have anything during their lifetime that decrease the number of their ovulatory cycle. You know, women ovulate every month since their puberty till their menopause. Studies have shown, and actually it's one of the researchers from Asyut University, it's called Mahmoud Fathallah from Egypt. He came up with a theory in the late 70s that anything that stops the ovulation decreases your risk for ovarian cancer by a significant amount. So the more pregnancies you have, the lesser is the risk. Actually, when you have more than 4 children, it's half as much the risk as women who are nulliparous without children. Women who breastfeed, especially more than 1 year, because during pregnancy and during breastfeeding, you don't ovulate. It decreases your chance of cancer. Women who take oral contraceptive pill decreases their chance, and this remains for over 30 years. So every 5 years of use of birth control decrease your chance of ovarian cancer by 20% and lasts for a very long time. That's why, for example, let's say a woman comes and she is at high risk for ovarian cancer because of family history or because of a gene, and she is very young. At a young age, I put her on birth control pill. So avoiding ovulation can do this. The other thing that we can do in women who are at a really high risk, and this is, I think, new thing that came up with our study, is that many of these cancers, not all of them, start at the distal end of the fallopian tube. You know, the fallopian tube is the tube that picks up the ovum and the sperm comes in and they have the fertilization in the tube. Studies have shown that a lot of women who carry this gene, the BRCA1 or BRCA2 and the other genes, the tumor actually starts at the distal end of the fallopian tube and then comes and gets stuck to the ovary and develop as an epithelial ovarian tumor. Studies have shown that 60 to 80% of women who carry these genes have this very early, what we call in situ carcinoma, a very early carcinoma in their fallopian tube. So what we are doing in these women, actually bringing them and removing their tubes, even if they are 25-year-old, we remove their tube. The other thing that we are doing in these women who wants to delay their fertility, let's say she's not married till the age of 30 or 35, and now she is really at high risk of ovarian cancer. We're getting them to do what we call egg freezing with pre-implantation genetic diagnosis. We're taking these ovary, testing them for that genes, and those who don't carry the genes, we freeze them, we put them in a freezer. If they are married, we fertilize them and freeze the embryo, and then take their ovaries and tubes out and leave their uterus for later on to return either the eggs after fertilization or the embryo. So there are so many things that we can do for these women who are at high risk, whether they have a family history or they carry one of these gene mutations.
It's really so encouraging for me to hear everything that you are talking about, all the exciting work that's happening. Indeed, our time is up, but I've really enjoyed this conversation today, Dr. Sioud. So many pearls that you've given about the current state, what women should be thinking about. in this day, World Ovarian Cancer Awareness Day. So thank you again for joining the program. Thank you for talking about our model of care at SSMC and our holistic approach.
Thank you, Matt, and it's always a pleasure to be here, and we're always ready to answer our patients. Thank you.
Thank you.